Welcome to the joint meeting of the American Society for Microbiology and the International Society for Chemotherapy here in San Diego, where we're attending the 55th InterScience Conference on Antimicrobial Agents and Chemotherapy, as well as the International Congress of Chemotherapy. For those of you joining us for the first time, welcome. This is a meeting whose focus is on antibiotic resistance, antibiotic development, and antibiotic stewardship. This meeting affords the attendees an unmatched opportunity for discussion and cross-collaboration. And now, with you joining us, you too have an opportunity to experience some of the science that's going on here this week. I'm Michael Schmidt from ASM's This Week in Microbiology, and it's my distinct honor to welcome some of the scientists that are presenting their papers and posters and talks here at this conference and have a discussion with them up on our couch, as it were. So we encourage you to ask questions, so please help me in welcoming our first guest this morning, Dr. Sally Hodder. Welcome, Dr. Hodder.
Thank you.
You gave a great talk yesterday afternoon. You had what they term a slide session, so it was one of the platform talks, and you had some really exciting data, and I'm going to cheat so I get it right. It's a long, distinguished title, so we'll go with the simple one. This was Gilead Stribild demonstrates improved safety and efficacy amongst women who switched from a multi-pill antiviral drug regime. And this was a component of what they term the WAVES trial, which is the Women Antiretroviral Efficacy and Safety Study. And this was the first all-women interventional randomized double-blind phase 3 study to evaluate the safety and efficacy of some of these HIV medications. So for those of them who weren't at your talk yesterday, give us the take-home message that you want our audience to appreciate.
Okay, all right. Well, thank you for having me. As you mentioned, though, half the folks living with HIV are women. Women have constituted a very small minority of the study populations in clinical trials. So as you mentioned, the WAVES study was the first study that was an antiretroviral study that enrolled all women. And it compared a fixed dose combination of 4 drugs, Elvitegravir, cobicistat, emtricitabine, and tenofovir, with a standard of care boosted protease inhibitor regimen, ritonavir boosted atazanavir with tenofovir and emtricitabine. The study enrolled women from all over the world. A third were from Russia, 20% from the US, 28% from Uganda, and the remaining 19% from various countries around the world. There were 80 study sites.
So you had the globe in this trial. So this is really
women in the globe.
Women in the globe. So this was really a groundbreaking trial because it, as you said, this is the first time it only evaluated this population, women, because everyone who's experienced puberty know that men are distinct from women and women are distinct from men.
Well, that's exactly right, and I think that we'll get to the study results in a minute, but one of the most important things that I think this trial showed is women living with HIV around the world do support clinical research, are terrific trial participants, and absolutely enrolled this trial. It was terrific. And historically, we've accepted 10% women in clinical trials. You know, regulatory agencies have made decisions based on very small populations of women, but obviously their approval is for the whole population. So I think that it's really important to sort of have this trial, and I'm a little biased, but I think that it's really a milestone because it was enrolled in all women. And the finding was that the fixed dose combination with Elvitegravir was actually better than the standard that we've used for a long time, which was the boosted atazanavir regimen. And the interesting thing is when the registrational trial was done in mostly men, the finding was a little bit different in that the two drugs looked very similar. So I think, again, it really points out as to why it is so important to make sure that clinical trials include women as well as men.
And this wasn't a small trial, as you alluded to. This was 80 study sites. There was a large patient population in this study, so this isn't a one-off event. These findings are truly meaningful and should change the standard of care for women.
Well, I think it's very important that this trial will inform providers on antiretroviral choices for women. You know, we're really blessed today in the field of HIV. Back in the day, I was an intern in 1980 in San Francisco at the dawn of the HIV epidemic, and went through a very dark period where, you know, our wonderful patients all died. And most recently, I was in Newark running an HIV program there, where roughly 40% of our clinic were women. And yet, as I said, most of the results had all been based on men. And so I think it's really becoming increasingly important. In fact, the FDA really had the drug companies, they said you need to sort of have more data in women, and hence the WAVES trial.
So let's start tearing the data apart. I know that you shared it yesterday with the ICAC ICC audience, so why don't you hit the high points that you'd like this audience here this morning and out on the internet to take away from the trial?
Okay, all right.
I know we don't have slides, but nevertheless, I think the data were sufficiently compelling that I think you can convey them orally.
Sure, no, absolutely. Well, this was a randomized double-blind study, and that means that you have 2 study arms, and each study arm gets the same number of pills. But in one study arm, you would have, for example, the Elvitegravir fixed-dose combination with pills that are dummies for the other regimen, and vice versa. In the boosted atazanavir arm, the dummy placebo would be for the Elvitegravir. So that really, you have randomization, randomized trial, sort of by virtue of randomization, hopefully will account for the confounders, because there is an equal chance you go into each side. Women could not have been treated previously with any antiretroviral agent. And we stratified, which means we made sure that there were equal numbers of women with high and low HIV viral loads, as well as CD4 counts. And as I mentioned, there are statistical ways to look and be able to conclude, is one drug better or are they similar? And as I said before,
the inferiority aspects
right,
of it.
But the Elvitegravir arm was superior. I think the other thing that was very important in this study is that the Elvitegravir was very well tolerated. The adverse events that we saw were really what you would expect with the atazanavir. The main problem there is that atazanavir results in a hyperbilirubinemia. You can have icterus or yellow skin. It is cosmetic. It is not a liver issue, but nonetheless, it's quite bothersome to some individuals. Elvitegravir does not have that issue. And there was a bit more rash in the atazanavir arm as well. Now, if we look at other sort of aspects, as I said, this was all across the globe, and there were, 3 populations that were really had enough women that we could compare. That is, 1/3 of the trial population in Russia, 28% in Uganda, and 20% in the US. And what we found is that the US women had a lower rate of virologic suppression. Virologic suppression is what you shoot for in HIV. You give the drugs to suppress the virus so it can't replicate. And that has been associated with better patient outcomes. In fact, today we know that individuals who are infected in their 20s, if they start on the antiretroviral therapy, they will live probably a normal lifespan, which is so different, than 20 years ago. So what we found, though, is that women in the US didn't do quite as well. And when we looked at differences among the regions, we found that US women were a little bit older. They were a little bit heavier. Their BMI was greater. They were less likely to be married. They reported a history of depression or anxiety more often than the others. And I think that this is extremely important and is really going to require much more analysis to look at what we need to do in the U.S. to really enable success. And you could sit here and say, well, that's impossible. We have everything in the U.S. Women in the U.S. should do better, certainly than a woman living in a rural village in Uganda. But I think that there are issues, American women, and again, in my clinic in Newark, I took care of most of my patients, not all, but most were women. And these women are very resilient, but they have a lot of responsibilities. Children. The poverty levels in many areas where women are living with HIV in the United States are quite high. So they're trying to feed those children, manage parents, and it is really a balancing act. And my personal opinion is women frequently put themselves last. Well, you can, really compare that to a place where there's a lot of social support. There may still be poverty, but I think that, some of those factors may be quite important. And I think the WAVES trial clearly put a focus on, women's health in the United States, and we need to take a very, very close look at that.
And it also, I think, suggests about the importance of getting tested for HIV. Typically, if you're sexually active and you're very promiscuous, you're very much aware of the HIV issues, and so you're likely to think about getting tested, whereas if you're not getting that messaging and you're not seeing it, you may not be aware of it. And so I think the healthcare teams need to do a better job of making women aware of the opportunities to get tested. And it just may be an issue of reaching out to the OBGYN community or something along those lines.
Oh, I think you're right, but I think there's another issue, and that is stigma. And stigma, despite the fact, that we are more than 30 years into the HIV epidemic, I think some communities have been very supportive, but I think many communities in which women live, they're not supported. And in fact, I had women who really did not want anyone to know they were taking HIV medicine. In fact, I think the simple, one tablet once a day have made it much easier for patients to be able to handle and not be taking a handful of pills, as happened 20 years ago.
Yes.
Which is really much, much better. So we have a lot of work to do there. If we looked at adherence in the different regional populations, we found that the virologic success, or our success in suppressing the virus, actually correlated quite well with adherence. And as C. Everett Koop said, if you don't take the medicine, it's not going to work. And I think that that's an issue. And what we really need to do is look within populations, what enabled success, what was predictive of success, and we have not done that yet with this data set.
Yeah, and I think that's one of the other exciting things is now that we have such good single pill, and this wasn't a part of your trial because you were evaluating the combination, and so now that we have these data, we can begin to look at virological success and how quickly the load drops because of all the unintended consequences of the side effect, and getting people treated sooner is the gold standard of all antiretrovirals. And this is a virus that doesn't discriminate. I mean, it knows no boundaries, it attacks everyone, it seems, equally. And
but I want to sort of bring up your point. I mean, women could have just said to their doctors, I want one pill once a day, but these women, the 575 women who enrolled in WAVES, actually signed up for taking more pills because
that's true.
They really understood and wanted to contribute. Is there, are women different? Is it better? What's very interesting about the WAVES study as well is this was, though the data were initially, some of the data, not all of it, were presented earlier in the summer at the International AIDS Society. There are a number of sub-studies looking at adherence with a novel methodology that analyzes hair. There's another sub-study that looks at flow-mediated dilation, which is an ultrasound technique that assesses the vascular impact of these study drugs in women. And I think that we really look forward to understanding much, much more about impact of antiretroviral agents on women.
So there's all sorts of new things that this WAVES trial has really helped to uncover, and I think if our friends at the FDA begin to look at the data, they'll encourage other drug development to look at this very important population to answer the question, is this as effective as the mixed trials?
Right, and actually, to your point, there is another all-women antiretroviral study that has been enrolled, and we should see, hopefully next year, the results of that with a different fixed-dose combination. So I think that the focus on women living with HIV and women's health is just terrific. It was a long time coming, but at least it's here.
How long did the trial take to conduct? I mean, I can well imagine with 80 study sites, it must have been a little bit like herding cats to get all the study coordinators lined up and do all of that. So it was a hard act.
Well, clinical trials always are. I mean, it sounds like it's simple. It's not simple. You know, folks have to be trained, the data have to be really meticulously collected, or you're not going to have confidence in those data. Now the trial, to the point that I presented it, was 48 weeks. You know, it took about a year to get it up and running and enrolling, but it enrolled very, very quickly. Again, I think reflecting the enormous support among women for participation in HIV clinical trials.
You're watching ASM Live here at ICAC ICC, and if you have any questions in the audience, please feel free to step up to the microphone and ask your question of Dr. Sally Hodder. Well, yeah, it looks like we're getting a question from the audience, and go ahead, state your name.
Good morning, Michael Smith, MedPage Today. My question actually has to do with the differential results between the registrational trial and your study. And that is, this was, Dr. Gattel actually sort of asked this yesterday, but I just wanted to ask again and see if I could like the answer better. That trial was smaller than your trial, if I remember the numbers correctly. It's about, did they have the same numbers?
It was a phase 3 registrational trial, and though I don't know the exact number, it was roughly the same. It was larger. Yeah, so we were 575, that trial was 750 individuals.
That answers the question. Then clearly, if you get a differential result, it's not a function of the size of the trials.
No.
Because they would have seen it if it had been there. Right.
I gave a bit of a flip answer to Jose yesterday. I said women are not men. That's true. But I think you have to be careful comparing across trial populations. I think that is very dangerous. And though, yes, we got a different result, we had a very different population, and there were many differences beyond just the sex of the participants. So I would not be appropriate to sit here and say we understand absolutely why we got one result with women and another with men. There were many other factors.
Okay, thank you.
Do you think as sequencing costs have dramatically been reduced, do you think we need to begin to genotype the populations that are in clinical trials to throw in the human genome component to this? And then the next big question is with the contribution of the microbiome, because and the microbiome, I mean everything, viruses, bacteria, fungi, because HIV, you're putting in this virus that achieves high titers inside a person, and it has to be interacting. And I think it's one of those black box issues that we don't yet fully understand. And we know that the microbiome can be influenced by diet, it can be influenced by lifestyle, you know, how much sugar you eat, all of these complex variables. And because you had a global trial with from under-resourced nations as Uganda all the way to the resource nation like the United States and the United Kingdom. So, you know, this is sort of outside of your trial, but do you think that as we get better with sequencing, that may be something else that we throw into the clinical trial mix?
Oh, sure. I think personalized medicine is obviously the way. And I think our colleagues in oncology clearly
have discovered this.
Now, they're looking and sequencing tumors, and it really is very predictive about what to use. I think in the HIV field, we have not gotten there yet, but I would speculate that you are absolutely right. And as we start to understand the impact of the microbiome, of the underlying, genomic polymorphisms, I would speculate that there absolutely is an impact.
Yeah, we already know from the old HIV literature that there are elite controllers that are based on their genetics as well as the genetics of the virus as well. So there's no telling what we might uncover.
Oh no, it's a very exciting time to be in medicine. It's and particularly I think working with clinical trials and research, sometimes with all of the bad press that healthcare sometimes gets, I think we lose sight of really the enormous possibility that I think we are just on the precipice of. So it is an exciting time.
And we really have to thank our study subjects who volunteer for these clinical trials, because they are truly the unsung heroes.
Absolutely. It takes a lot of time filling out the surveys.
Oh, yes.
Coming to clinic much more often than you would have to if you just got one pill once a day. And I would also say not only, our enormous thanks to our participants, but their families, the children that come and sit in the waiting room,
oh, yes,
the partners.
The chairs.
They really are the unsung heroes.
Another question from the audience, please.
Lynn Peterson with Trends in Medicine. So this is a trial in just women.
Yes.
But you're saying the results are different because you're doing a historical control with men.
Correct.
But shouldn't the trial properly have been done men against women? If you really want to see a difference, it could have just been this trial had different results.
Yes, and in fact, the problem has been that historically in registrational trials, such as the registrational trial that had the same study arms that included men, those trials, for whatever reason, have had small numbers, 10% of women, making the comparison, not having sufficient numbers of women to make the comparison. And I think your point is absolutely accurate. It is true that we got a different result, but the populations were different. And as I said earlier, sure, the sex of the trial populations was different, but there were many, many differences as well. You're absolutely right. Yep. That's absolutely right. That's absolutely right.
Yes, I always, when people talked with me about one of the clinical trials I was involved in, science is the art of the possible.
Yep.
You're always budget limited and study subject limited, and you try to answer the question for which you were tasked. And you were tasked to ask a very direct question: would this regimen work in women? And the answer was in the affirmative. And that, I think, is tremendously important. And it may encourage us to then ask the question, what about men? But there's only a limited amount of resources than which we can expend clinical trials, and every regulatory agency is hoping for a 50-50 mix and hopes. But again, as you segregate your groups, your power goes up, or the number of people you need to enroll in order to achieve the power.
I would say, though, that if we hadn't done this study, you would have a study with the same trial arms, 90% men, it was non-inferior. So I think the issue is we looked in women, and for women it was better. And we didn't make that conclusion. No, in women, we can say that the alvitegrivir arm was better than the boosted atazanavir arm. We can say that definitively from our trial in this study population. That conclusion could not be made with the previous trial that had a majority of men. So we can absolutely say that.
Okay, you're watching ASM Live here at ICAC ICC, and Ray was just playing with the mic. He didn't have a question. So if there are no other questions, I think this brings this session of ASM Live to a close. I'd like to thank my guest, Dr. Sally Hodder, who is from the let me get this right so I don't mess this up. The West Virginia Clinical and Translational Science Institute in Morgantown, right?
Correct.
I got that right. That's good. I'd like to thank you and especially our audience for your questions as we conclude this session of ASMLI here in San Diego. And please join us for our next episode, which will be very shortly at 9 a.m. Pacific time. And this and all of our ASM Live episodes are archived on our ASM Live website at Microbe World. Thanks again, and be sure to take the opportunity to follow us on another podcast, TWIM, TWIV, TWIP, and our newest podcast, Microbe Magazine. And until next time, I'm Michael Schmidt for This Week in Microbiology. Thank you, everyone.
Thank you.
Did great.
Once you're in the BSL-4 space, the only way you can get out is to go through a chemical shock.
It's an unusual room, never seen anything like this. Anybody who has access to this facility first has to go through an R scan. So the HEPA filters filter the air coming out of the facility, and that will remove bacteria, viruses, anything that might constitute any kind of risk, right? Remember, this building is basically a second building inside the main building.